everybody, we're going to continue working on the endocrine system. This PowerPoint will take us through the remainder of the pituitary gland hormones. Well, we previously were talking about how the hypothalamus stimulates the anterior pituitary to make and release its own hormones. We just got through talking about growth hormone, and now we're going to pick up with this one here, thyroxine. So the hypothalamus produces a releasing hormone called thyrotropic or thyroid releasing hormone. Keep in mind that RH there is a reminder that we are looking at a releasing hormone made and released by the hypothalamus. We know these releasing hormones target the anterior pituitary. In response, the anterior pituitary makes and releases its own hormone called thyroid stimulating hormone. We talked already about that SH being a good reminder that we're dealing with a hormone that's possibly coming from this anterior pituitary. Notice that thyroid stimulating hormone continues on by targeting the thyroid gland to release thyroxine. We'll talk more about thyroxine when we get to the content on thyroid gland. So this is a chain of events that starts with the hypothalamus, continues on to the anterior pituitary, and then results here with our thyroid gland. Okay, and so the order of hormones released are TRH to TSH to thyroxine. Most of our hormones do operate on a negative feedback loop, as you can see here. The feedback loop operates between the thyroid gland, hypothalamus, and pituitary gland. So if thyroxine levels are low, that stimulates the hypothalamus to tell the pituitary to release more TSH, or thyroid stimulating hormone. Likewise, if thyroxine levels are too high, that will inhibit the release of thyroid stimulating hormone. All good negative feedback examples. Let's talk about the adrenal cortex for just a moment. The adrenal cortex is the outermost portion of the adrenal gland. We call that outermost portion the adrenal cortex. The innermost portion is called the adrenal medulla. The hormone produced by the hypothalamus that gets the ball rolling here is called corticotropic releasing hormone. First off, we know that RH is a releasing hormone. It's made by the hypothalamus to target the anterior pituitary. Secondly, this prefix here, C, stands for corticotropic. Great clue there. Cortico means cortex. So that's a wonderful reminder that we're dealing with a hormone that ultimately influences the adrenal glands. CRH, coming from the hypothalamus, does target the anterior pituitary. The anterior pituitary now makes and releases ACTH. So I want to break that word in half there. We know that TH is a tropic hormone. This is coming from the anterior pituitary. But let's talk about AC. A stands for adrenal, C stands for cortex. So just another great reminder of where this hormone is heading. Now we see the adrenal cortex stimulating hormone, or ACTH hormone, targets the adrenal gland to release hormones. We'll talk more about some of these. They include hormones like cortisol, aldosterone, for instance. Some great hormones we'll talk about a little later. So once again, we see the pathway from the hypothalamus to the pituitary to the adrenal glands. And of course, CRH promotes the release of ACTH, and that promotes the adrenals to release hormones like cortisol and aldosterone. These are all slides from page 7 in your course pack. They are great for turning into flashcards. You may want to use some of these terms as blanks on a flashcard and see if you can keep this pathway right. Once again, this is a negative feedback mechanism that plays between the adrenal glands, hypothalamus, and pituitary. Let's talk about GnRH, just a good clue there to look at. GN stands for gonads. Don't get this one confused with GHRH. That's going to be growth hormone releasing hormone. These two are not the same. Okay, there's that RH ending. We know that's a releasing hormone. We know they're produced by your hypothalamus. They target the anterior pituitary. In response, the anterior pituitary releases FSH, which is follicle stimulating hormone, and LH. Both of these hormones are found in females and in males. So they're not necessarily for one sex over the other. Now, FSH and LH will target the gonads to release sex hormones to produce sex cells. Most of this gets started at the time of puberty. So once again, the hypothalamus sends a message to the anterior pituitary, and that of course sends a message to the gonads. GnRH promotes the release of FSH and LH. Those hormones encourage the release of other hormones like estrogens, progesterone from the female's ovaries, or testosterone from the male testes. We'll talk more about this at the very last chapter of this course. The last one on our chart, page 7, is prolactin, and as the name implies, pro means in favor of or for, and what does lactin mean? That means milk. So in which sex do you think this particular hormone operates? This one's for females, right? So notice that this particular pathway that we're looking at is for the production of milk. When do females produce milk from the mammary glands? When babies are present, right? So after pregnancy, baby's been born, baby's nursing, that's when we expect to see milk production. So prolactin releasing hormone is needed then. It stimulates the release of prolactin from the anterior pituitary. And of course, prolactin targets the mammary gland to produce milk. Same flow path. Hypothalamus tells the anterior pituitary. That, of course, tells the mammary glands what to do. So in this case, prolactin releasing hormone encourages the release of prolactin, and that encourages milk production. The only time this particular hormone should be active is for a breastfeeding mom. Interesting stuff about this hormone, we know that babies crying, any baby crying, might be the stimulus for prolactin release. So that's a neural response, right? A neural stimulus. We also know that babies suckling from the breast can also encourage prolactin release. Yet again, that is another example of a neural stimulus. Now, in everyone else who doesn't breastfeed, or males or non-lactating females, we don't expect to see prolactin releasing hormone in control of our breast tissue. We would expect to see prolactin inhibiting hormone. There's that IH. Normally, this hormone keeps the milk production turned off. That's what we want to see in someone who is not lactating. So you'll notice that keeps this process here. We don't get mammary glands producing milk when PIH is in control. Now, if there's a female or even a male who produces milk or has secretions coming from the nipple when they're not breastfeeding a baby, that is certainly something for concern and to be looked into. So, normal situation of non-breastfeeding, non-lactating humans, we expect to see PIH in control. All right, so just another feedback loop here. This one is actually, in fact, positive in nature because as long as the baby is breastfeeding, we expect to see this one being produced. Back in the day, wet nurses continued milk production long after the baby was weaned because they often fed other babies. So if a mom had a baby and her milk didn't come in immediately, the wet nurse could step in. That means that women might have been able to produce milk for years beyond the time that their own babies were weaned. There is still conversation about breast stimulation and full-term pregnancy leading to the birth of a baby. That's, there's camps that say no, that can't happen, and some that say yes, that can. So we are not entirely certain that breast stimulation can cause the birthing process to kick into full gear. We already talked about male lactation, but we know that in the case of males who produced breast milk, that should be looked at because there could be something else going on in the breast tissue. That is not a normal situation, we know. All right, so that should finish up page 7 for us. Let me take you on over to page 8, and we will now talk about the posterior pituitary gland. We know the posterior pituitary is made up of nervous tissue. It is not made up of endocrine gland tissue. And you'll also notice this neural connection between the hypothalamus and the posterior pituitary. In fact, these are neurons that originate in the hypothalamus, and they do travel with their long axons down here into the posterior pituitary. If you look closely, these are axon terminals right here. They sit on a blood supply, and when stimulated, they will release one of two hormones. Antidiuretic hormone is known as ADH, and the other one released here is oxytocin. Let me make the point once again that ADH and oxytocin are produced here in the hypothalamus, and they are released from the posterior pituitary. So the posterior pituitary does not make its own hormones. It only serves to release those stored there and then, of course, stimulated by that hypothalamus. Let's talk about oxytocin first. This particular hormone targets the uterus and the mammary glands of females, so I'll just make note again that this is females. And the jobs are to promote a set of muscle contractions in the uterus of a female. That could be during menstrual cramps, that could be during orgasm, that could also be during childbirthing. So oxytocin can promote those uterine contractions. Also, oxytocin stimulates the mammary glands in a process called the milk letdown or the milk reflex. Now, let me talk to you about how oxytocin and prolactin play a tag team approach to milk production. In order for milk to be produced by a female's mammary glands, oxytocin must first be made. Oxytocin initiates the flow of breast milk from the mammary glands. That initial flow is called the milk letdown or the milk reflex. That involves the baby crying or baby suckling from the breast. Prolactin comes in and maintains milk production as long as the baby suckles. So if you don't have oxytocin, prolactin is unable to do its job. Does this sound familiar? This sounds like a case of permissiveness. Oxytocin gives permission for prolactin to do its job. There is little function known in males, of course not for uterus or mammary glands, but in males we expect for this hormone to make them feel good just as it would in a female. This particular hormone is often known as a bonding or a love and trust hormone. In fact, it's sold in nasal sprays. Not sure how effective that is because this particular one does not cross the blood-brain barrier. All right, so let's spend some time now talking about antidiuretic hormone, or ADH. Okay, so first of all, let's talk about the word anti. That prefix here means against. What do diuretics make us do? Diuretics make us urinate. So let me just write in up here that antidiuretics are against urination or urine formation. So keep in mind, this particular hormone promotes water retention. It is against the formation of urine. Don't think of this as a hormone that makes you bloat. Instead, think of this as a hormone that prevents you from dehydrating and drying out. So antidiuretic hormone is responsible for making sure that you don't pee out and lose a lot of the fluids in your urine. So its alternate name is vasopressin because it also increases blood pressure through water retention. Vaso, of course, meaning vessel here, and pressin indicates to me squeeze or constriction. Okay, so we're looking at a hormone that increases water retention by your kidneys, keeps you from drying out and being dehydrated, and increases blood pressure through vasoconstriction. So we know, and we'll learn later, that water is a big contributor to your blood pressure. So the more water you retain, the higher your blood pressure is going to go. Now, let me also talk to you about osmosis for just a moment. Back in Bio 210, you probably learned that water follows salts or solutes. We know that water travels to the saltier area or compartment. When we talk about it in this context, we call that saltier area a higher osmotic pressure, this term right here. So what we understand is if you have a lot of salt in your bloodstream, then your body will retain water. And the goal here is to reduce the saltiness of your bloodstream. And the way you retain water is through the actions of antidiuretic hormone. It will insert aquaporins or water channels in your kidneys tubules and allow you to reclaim that water back from the forming urine. So thinking big picture, when antidiuretic hormone is in control of your urinary processes, do you think you'll pee out a lot of dilute, light-colored urine or a small amount of dark-colored, concentrated urine? You'll actually urinate small amounts of dark yellow concentrated urine. Okay, and the reason for that is you're keeping the water, it's coming back in your bloodstream. So let me give you an example. If you've had a bag of salty potato chips and you had nothing to drink with it, wait about 30 minutes to an hour and you might start to be feeling thirsty. That's part of a thirst mechanism, and in the meantime, antidiuretic hormone is also telling your kidneys to reclaim water from the forming urine. If you don't drink anything, then you'll pee less the next time you go to the bathroom because your body is keeping that water thanks to ADH. Just a question down here at the bottom to address. Alcohol actually inhibits ADH production and release. So in the case of alcohol being in your system, we'll see an increase in urine output. That's why alcohol makes people urinate frequently, and it's dilute, light-colored, large volumes of urine. So alcohol will shut down ADH production. Just want to spend a moment talking with you about diabetes insipidus. This is not the form of diabetes that we commonly hear discussed. That other form is called mellitus. This particular form of diabetes comes from the hyposecretion of ADH. It's a rare form of diabetes, and you'll notice there's nothing here on this page about blood sugar levels or insulin problems. This simply comes from the fact that ADH is unable to cause water retention at the kidneys. So if ADH is unable to be produced by the hypothalamus and released from that posterior pituitary, we will see two conditions arise. Polyuria means excess urination. What about polydipsia? There's that prefix again. This time it's excess thirst. Notice, no problem here with sugar, no problem here with insulin, and this condition, diabetes insipidus, will make you thirsty. So I remind myself that you would be sipping because you're thirsty, okay? So this particular problem is not diabetes mellitus. It's not dealing with sugar or polyphagia or any other condition that comes with that particular form of insulin problem diabetes. This one here can be diagnosed through an MRI or perhaps a brain scan that would allow us to see what's going on with the hypothalamus and pituitary. More information there at diabetesinsipidus.org.